725. Came just in time. Not ready with that.
People are still joining Sanjeev, eh?
Yes. Hello, Rahmat. Hello, Lakmat.
No, then
ලක්මාල්ව බ්‍රේක් කැඩෙනවා නේද?
Some problem with, I think, data.
Sometimes when you, yeah, without the video, sometimes it can be better.
Sanjeeva, now can you hear me?
Yeah, we can hear.
Clear. Much better. Very clear.
Thank you, sir.
So shall we start now then?
Yes,
Shall we?
suppose.
We should start now. 7:05 ni දැන් නේද?
Yes, I think we should
Yeah.
start.
Sanjeev, yeah.
Okay. So, very good evening, dear teachers, dear colleagues, and ladies and gentlemen. Now we are going to start another session on humane care. On behalf of Sri Lanka College of Internal Medicine and Expert Committee on Humane Care, I would like to welcome you all for the program today. You all know that the college theme for year 2022 is Enhancing Clinical Excellence, Capacity Building and Humane Care. The Expert Committee on Humane Care is working hard to achieve these goals. We had a wonderful and fruitful panel discussion last time, and one of the suggestions they made was storytelling is a very good way of encouraging humane care among healthcare professionals. Actually, this session is based on that suggestion, and we will have very interesting stories from our colleagues to listen this evening. This is how we are going to conduct this program today. At first, President Sri Lanka College of Internal Medicine will address you, and followed by a presentation by an eminent speaker on learning from narratives. Thereafter, we will have lined up 10 stories, which will be presented by our expert in the medical field. After each story, there will be 5 minutes for comments and questions by either panel or audience. Further, after all stories are finished, there will be another 15 minutes to comments and suggestions. And last, closing remarks and word of thanks. I have to leave few messages for you all. Please keep your microphone off during the session to avoid unnecessary noises which can distract and disturb you all. And during your presentation, keep your video and microphone on. Please raise your hand in Zoom when you have a problem. And most of the speakers are here great physicians and teachers ever we had. I apologize for brief introduction on them because we have to manage everything in a short period. Further, I can watch this. You can watch this program live on Facebook page on Sri Lanka College of Internal Medicine too. I can see now over 70% participants already. Thank you so much for joining with us. Without much talk, may I invite Dr. Ganaka Senaratne to address you. I don't think you need more introduction about him. He's a president of Sri Lanka College of Internal Medicine and specialist in internal medicine. His enthusiasm and dedication on this regards are enormous. Over to you, Dr. Ganaka.
Thank you, Sanjeeva. Very good evening to all of you. Prof. Saroj Jayasinghe, Emeritus Professor of Medicine, Dr. Raghunathan sir, and Prof. Pandu Karunanayaka, Dr. Sarath Gamini, very senior consultant physician and past president of CCP, Dr. Kitri, my good friend joining from UK, Dr. Lakmal, Hasheni and Lushanti, our consultant physicians, Sahan, our senior registrar in internal medicine, who will be sharing their experience with us today. Past presidents, council members, and members of expert committee on human care, senior registrars, doctors, and all other colleagues of other healthcare teams, such as Director Nursing, Ms. Saman Mali, who's joining with us today, and my ladies and gentlemen, and my dear students. So as Sanjeev said, the college has been, I warmly welcome all of you for this session again. College has been functioning under the theme of enhancing clinical excellence, capacity building and human care. So we have established this expert committee to plan and conduct activities right throughout the year. College believe that through these activities that we will be able to inspire and ignite our members on bringing compassionate and empathetic care to practice. I must thank the expert committee on human care for organizing all these events, and Sanjeeva, who's very passionately coordinating all these activities. So I sincerely believe that this storytelling session with sharing of our heart-touching stories about our beloved patients will ignite and inspire entire healthcare community to arrange compassionate and empathic care. Without taking much time, I would like to hand over the session to Sanjeev back again. Over to Sanjeev. Thank you.
Thank you so much, Ganaka. May I invite our next speaker? Is a well-known person to medical profession. It is an honor and privilege to introduce him. Professor Saroj Jayasinghe, Emeritus Professor and Specialist in Internal Medicine, Founder, Head, Department of Medical Humanities, Faculty of Medicine, Colombo. He's a teacher and role model to medical professions. He'll be talking on learning from narratives. Over to sir.
Yeah, thank you very much. Thank you, Ganaka, and thank you, Sanjeeva and the team for inviting me. I will be very brief. I will speak to you about storytelling or narratives, and it's how it's useful and important for the medical profession. Just to look back to ground this, sometimes we don't realize that what storytelling means. Actually, it's a way of knowing about the behavior of others, and that's a basic social need. In fact, even in evolution, the fact that we are cooperating with each other and we are able to, we have developed to this extent, our civilization is believed to be due to this cooperation, not competition. You see, the survival of the fittest is not individual survival of the fittest. That's what people have misinterpreted it. and to be competitive based on that. But actually, human beings are cooperative. They are kind rather than competitive. And our evolutionary edge is because of this cooperation. So storytelling is now believed to be an important part of that. And in our childhood, you can remember the stories, how we used to love to listen to stories. Our mothers or people who were looking after us would talk about stories. In schools, we always had stories. And even in our culture, if you look back, the Jataka stories have been used to imbibe certain values in us. And Professor Harishchandra from Karapitiya, in fact, has published a book on trying to tease out some of the lessons we can learn. And most of the sermons by the Lord Buddha, he would always bring in a story and elaborate a principle. And you get this even in Bhagavad Gita, in the Hindu philosophy, you get it in fairy tales, and so many other cultures where they talk about, where they use stories. So it's a fundamental sort of part of our society, of our civilization. And we see it even in other religions. They will speak about the religious leaders, the life of Jesus Christ, the life of Holy Prophet, and so on. So in evolutionary plus in our childhood plus in culture, and the fourth C is actually in our clinical practice. So in clinical practice, when you listen to stories of patients, not their history, but their stories, their life story, what brought them to you, what were the lives they had before falling ill. If you just allow them to speak and listen, you soon develop this rapport with them. And this gives a glimpse into their lives. So even though the patient may be presenting with a certain disease, how it affects that person, the fact that they have to, just to visit the clinic, the fact that they have to find people to look after the children or cook the dinner for the family and leave home hours before to arrive at the clinic just for 5 minutes, right? So you begin to understand their real lives, and it's well known that if you build this rapport and understand the patient in their context, we do have better outcomes. So clinically speaking, there is enough evidence that listening to stories and responding to them appropriately and sensitively is beneficial in the care of our patients. And certainly it's good in its own right, even if the outcomes are not affected, because you are speaking to another human being. And this brings to this whole initiative of narrative-based medicine. And there is a lot of work on this area, what we call narrative-based medicine, and this narrative competence, this ability to listen, to absorb their stories, and to interpret those stories and respond to them. Now, we've done this. We started this in Colombo, actually, in its infant form in 2012, when we sent our students to the wards. In the third year it was, but we've sent them before also. But this time we told them, tell us the story behind the patient. Write a short story or a novel. That was the task given, not to take a history, not to take a history with a view to diagnosis, but write a short story or a novel which will capture this patient from the day the person was born, where they lived and where they went to schooling and so on. And we got them to do that in Sinhalese or Tamil, not translating it. Because when the moment you start translating it, unless you are really, really good, you miss the rich aspects of these stories. So, and it was quite revealing how they came and presented their stories, and some of them were almost, almost tearing, because they had listened to the patient who had a stroke and was being treated as a stroke. When they find that the patient came from Jaffna in the train, didn't have anything else with him other than his small bag, and he is now aphasic in the ward with hemiparesis, unable to give any sort of identity or name or address, right? That's the sort of revealing thing revealing background which came up. So I think it's important to realize that narration and storytelling has it's a very important and a useful way for us to become sensitive to patients, to listen to them, to understand their lives. And using narration or storytelling, we will hopefully develop more empathic and more compassionate medical professionals and health professionals. And the fact that this is deeply rooted in our evolution, in our cultures, and in our childhood. And also there is enough data now that such narrations, such stories do benefit us in providing care. So thank you very much. And once again, I must congratulate the college for taking this initiative and for taking this forward. Yeah. Thank you.
Thank you so much, sir, for your nice elaboration on how we can learn from the narratives. We don't allow at the moment to ask question from you, and because we have another 15 minutes at the end of all the stories, we can discuss further on this topic, sir. And now we are moving to next event. Let me to introduce next speaker and storyteller. Dr. M.K. Raghunathan, specialist in internal medicine and past president of Ceylon College of Physicians. He's a passionate with humane care, and he's a great teacher ever we had. Let's listen to his story. Over to sir. Raghu sir, Raghunathan sir, can you hear?
Sanjay, he's muted, neither.
Is it?
I can see he's muted. Now it's okay, I think.
Okay, thank you very much, because I was struggling because it's not allowing me to unmute because you're the admin. You have unmuted. Sorry about it. Okay, hopefully you can hear me now.
Yes, sir. You can click.
Okay.
It's clear.
Well, right throughout my career,
Can't hear, Raghu.
yeah. Now, can you hear me now?
Yes, now we can.
Okay, so right throughout my career, I have been telling stories to all my students, my staff, and this always fascinated me. And this actually started with, I am just continuing from what Saroj said. I was in 2012 in Colombo when Saroj started this. And it was a wonderful thing that I learned to let the medical students who are coming in to the clinical board for the first time to see, not to take a serious medical history, but to listen to the story. And I must, I recall this story, I don't know where I got it, if I'm wrong in some information, pardon me. I think in Harvard University, one of the professors asked the students, go to your patients and see the most, the least interesting patients you have, and to try to dig out the story from them. So all the students went to these patients, and one of the patients was in the corner in one of the side room, totally, not interested in anything. And he has been discussed as a case of this and that. And when the student tried to get the story from this patient, he had a scar somewhere. And the student asked, what is the scar? And he said, there was something big fell on my forehead, a large barrel. That's funny. How did the barrel come and fall into your forehead? And he said, no, I was traveling in a ship and the ship started drowning. And to see, it was a man, a survivor of the Titanic, who is in the ward. No one knew about the history. So this is how that university started making the students to learn from storytelling. And I thought this is a wonderful thing which Dhanaka and College of Internal Medicine is doing. And I must confuse last 6 or 7 days, I was trying to tell which story to tell. Every day I have been changing. And today in the evening, I told my daughter what the story I'm going to tell. Now in the next half an hour, I have changed what I'm going to say. That can tell you how many stories each and every one of you must be having. So pardon me, now only I'm going to start telling my story. The story is of a medical student or a student in a girls' high school, a good friend, a very good friend of my daughter, second daughter. And she was, the family is also known to me. That makes things complex. And she came to see me one day in the private sector with cough and cold. So I treated this girl with cough and cold, and that's it. I forgot about the patient and they forgot about it, didn't come. Later, the mother, there is a fatherless child, and the mother called me and said, Doctor, my daughter is now in National Hospital, Colombo. She is having some problem. Can you please let us know what to do? So I made a social visit to actually Saroja's ward, and with the permission from whoever is there, to see what has happened to this girl. And this girl has got a piece, has gone with the cough and cold did not subside, has gone to Dr. Chandima Dimal at Navaloka. Everyone goes to him. And he has diagnosed PCP pneumonia and handed over the patient to Professor Shyam Fernando. So the patient was in Ward 48, if I remember right, was there. I went to see her socially. And what is PCP pneumonia? And a young girl who has just finished O-level. And I have to tell the story of this girl. And this girl, 4 or 5 years ago, was in my ward. And that is the very first epidemic of dengue. And we were giving a platelet for everybody in the ward. If the platelet drops or if the patient gets a reaction to something, everybody was pumped in. And I must confess, there was no guidelines, no local guidelines at least. This girl, I must confess, had platelet without any proper indication. And this story was not known to the treating medicals. So then that is something I had to, I have gone to see this patient socially, but I have a responsibility because this patient, this girl would have possibly got the HIV from the platelet transfusion given. So Dr. Ananda Vijay Vikrama, who gave the permission to tell the story a couple of hours ago, got involved. And so to treat this patient in IDH, antiviral drugs was very expensive and not available 15 years ago. And to do a PCR was not available in either in the STD clinic or in the STD clinic or in IDH. So I made an appointment on Wednesday to meet the late DG, and I was waiting 1 hour outside the DG office. There was a team of 8 people, to give 8 people have come, and all the directors are writing up a report about the AIDS situation in control. And I overheard this, eavesdropped this. They were saying everything is fine in this country. AIDS is being done. We are having everything controlled. Here there is a girl who has got HIV. Dr. Ananda is unable to do a PCR either in STD or in IDH. and they are writing a report saying that. So then I couldn't wait anymore. I barged in and I said, look, sir, this is the girl who has had played most likely 4 years ago given platelets. She has got a O-level student, my daughter's very good friend in a leading high school. This is most likely would have happened. And the story, the response I got was, how do you know? How do you know it is from your platelet? She would have get it from anywhere. This is a mind you O-level girl. The ministry officials are saying this girl would have get aid somewhere else. So I insisted, no, this cannot be left like that. We have given platelet. So I came to the hospital, got the director general, Director Karapitiya and the blood bank, everyone to trace what the platelets were coming. They were able to take the platelets, platelet concentrate. 2 donors were missing. So the STD campaign couldn't, or the blood bank couldn't get 2 trainers. In the meantime, there was the story coming from the school. Now, Ananda and I have the role to play as a physician. We went and met the principal in the Southern School and said, this girl who is now in the hospital going to come, she has got HIV, but no one is, we are not declaring it, but it may come to you. She threw a fit. She said there is no way she can be admitted to the hospital or school, and we had to threaten there will be huge, you cannot do it, and it has to be done. And we had to do a lot of Ananda and myself in the principal of the leading school have to make sure this girl can be. And then this girl is from Akurasa. They couldn't get a boarding place. So we had to go and speak to the boarding place. And in the school, this girl has to made to sit next to my daughter, so that people will know that HIV doesn't spread by close contact. And then that is how this the problem in the school and the problem of the boarding house was sorted out by Ananda and me. Then what happened? This continues. Everything was Ananda was able to get and the DG at last gave the permission to local purchase or got down the PCR thing for both STD and it's IDH, thanks to this girl who got HIV given by, possibly given by our platelet transfusion. Subsequently, it was found out one of the donors 2 or 3 years later, who is from South Africa, who is a homosexual or something like that, came and he himself has declared that he is one of the donors. So now, after many years, this has it has come to light where the platelet, how the platelet given in my unit has caused HIV to this innocent girl. That's not the end of the story. Everything was gone, and Ananda was in full control, and she got the better PCR. Everything was doing well, and but she was not given any compensation. She was not given any job, and but subsequently the media. This is what where the media. I'm sorry for I'm taking more than 5 minutes. The media in one of these inside story in the Island paper said that then the Prime Minister Mahinda Rajapaksa was traveling with his wife in a car, and the paper reporter was in the car, and the story has been told. And in this thing, the health department is trying to cover up all these things under the carpet. This has to be, whereas we are going out of the way to find out how we gave, how she got it, and everything was clear. Many years later, the media is declaring we are trying, the health department is trying to cover up the story of this innocent girl. So anyway, thank God, the good story, the good result is Ananda has completely cured her. She got married and she has a child and is living abroad with her husband. So this is not the story narrated, or maybe not the story narrative straight from the patient. This is the story of a girl. But how much things can go without being noticed unless people take this thing. And I must thank Ananda for that girl is now a mother of a child living happily with everything. And understandably, she is not getting any contact with the friends. That is totally understandable. Thank you.
Thank you very much, sir. We know you are how committed to the patient, sir. We know you have 1,000 of stories to tell us. And are there any comment from the audience or expert panel?
Sorry. Yes,
Yeah,
Ganaka.
sir, go ahead.
Well, thank you very much. Thank you, Raghu. I think that was a very interesting story about a patient. It brought out the patient's issues as well as a story related to what really happens in the health service. And when we have to tackle sensitive issues and sensitive, sensitive clinical situations and the background to it. So I think there the learning points would be, as Raghu himself mentioned, it's more not so much related to the patient's narrating a story, but a story nevertheless of a whole series of events, which shows how complicated the clinical care can be. So thank you very much. I don't know whether others want to comment also. Thank you.
Yes, anyone wish to comment on?
So can I add something, Ganaka?
Yes.
That tells how compassionate Dr. Raghunathan and the team on her care.
No, sorry,
and
sorry,
planning.
Ganaka. That's not the point. Sorry, tell anything else. Not the commitment. The whole story is. I know it's not the narrative of the story, but narrative of the patient. But I think the story, as Saroj said. Thanks, Ganaka. But please do not put me embarrassing situation.
Sanjeeva, I would like to add a little bit of a thing to. I think I know this as
Yeah.
a trainee. I can remember this girl. Once again came when I was I think I was senior registrar in Sir's ward. And the reason why I am talking is that that time we had a wonderful set of house officers. I can remember in one occasion when the girl came to the ward, they knew her and all her close contacts, blood drawing, giving IV drugs and all done by our wonderful house officer team. Even they didn't even allow the nurses to approach because they understood the team's emotions and all. So they were so caring. I should mention most of them, I think, if I correct, Darshana is one. Darshana, now one of our famous physicians in the SLSIM, is one of them. They were so caring towards that girl. That's the way they dealt with the patient was still I can remember nicely. I think that inspiration we got out from our ward, from Sir and all.
Thank you so much, Dr. Hasheni. Anyone would like to comment? We have 1 minute.
Is there any provision for getting compensation in such cases, even now?
Thanks for asking this question, Sarat. Actually, she was after many years she was given a house by the state. After many years, she was given a state house. Yes.
But that is, I think, by the individual politician concerned. But there is no other scheme for payment of compensation when it is obviously the fault of the health service. No.
I don't know.
Okay.
Okay, sir. Thank you very much. May I introduce next speaker and storyteller, Professor Panduwa Karunanayaka, Professor and Specialist in Internal Medicine, Chairperson Humanities, Society and Professionalism, Stream Faculty of Medicine, Colombo. He's a great teacher and researcher on medical humanities. Over to sir.
Thank you, Sanjeev. Thank you very much. I'm not a great teacher or researcher, but anyway, thank you. So thank you also for inviting me, and my congratulations to the SLCIM for this very interesting and pioneering effort also. I was wondering which story to tell today, and I thought I'll bring a story from my medical student days, rather early. I think the year would have been maybe 1991 or 92, when I was a final year prof appointment student in the professorial unit in medicine in Ragam. So as you know, when we are medical students, we all have a different set of fears and anxieties about having the case history ready for your professor and having all the details ready, making sure you don't miss anything, so many other things, and you have a different set of anxieties in your mind. On the other hand, there's also the anxiety that or the feeling of being a useless person because you're not qualified in medicine, and I don't have any qualifications, I don't have any special skills to offer, and I'm just someone who's floating in and out of the ward. And the patients also know this, and they also see us as like Karadara Karyo sometimes. And we also know that they look at us in that way sometimes. So our mentality as medical students is very different to what we are now, obviously. So I was carrying all this in my mind with that day, and I had a patient. She was in her late 30s or maybe 40s. She was a Muslim woman, and she could not speak any Sinhala. She was only able to converse in Tamil, and unfortunately, I did not know any Tamil at that time, so I could not talk to her at all. And taking a history was a big challenge. She was there being investigated for proteinuria, so she was going to get a renal biopsy very soon. And I would struggle to take a few little bit of details about age and all those things, and get some stuff from the BHT. And if I could get a translator, I would get someone to ask a few questions, and then she would give a yes or no answer, and that was my history. And there was actually, we have been talking about narrative medicine. I have to confess, I don't have a narration because the patient couldn't say anything to me. There was no possibility of verbal communication with her at all. So anyway, I could even see when I just went away to some other place, I could see her talking to the other patients and just, like joking about me, saying, like how incompetent this fellow is, can't even converse with me, that sort of thing. So I was feeling very inadequate also. But anyway, on the day of the renal biopsy, I stayed by her while the biopsy was being done. And when I was there, when she saw me, there's a separate biopsy room, where the biopsy is done. When she saw me coming into the room, she seemed to lighten up a little on her face, and she seemed to feel a bit more relaxed or a bit more grateful that someone known to her was there, although we could not talk. And then, biopsy was done very safely. No problem happened, no pain and all that, good anesthesia. And she was taken back to the bed. And then I kept on checking the blood pressure every hour, the monitoring stuff and all that. And now she's realizing that I am of some value to her. And I'm also very happy. And then, so I stayed on till late at night. Normally you have to stay and clerking patients now. So each time I was going past the bed, I would check on her and all. And I went home, not home, I'm to my chamari. And the next morning again I came, and when I came the next morning, I saw her face was looked very uncomfortable. I couldn't say why, because she didn't look the normal comfortable sense. She didn't look healthy. So I was worried. I thought maybe a complication, nothing hemodynamic. Checked her temperature, it was normal. And then I thought I'll examine her biopsy site, and I just removed the plaster. And I thought there was a small drop of like serous fluid coming out, little small drop. And I just palpated there and pressed a little to see there was a small mucopurulent, seropurulent discharge coming from that. So that means infection. So I quickly closed that, and I ran to tell a doctor. The doctor who was there was Uday Ranavaka, who is now a professor in Kelaniya. He was, I think, either SHO registrar when I was a medical student. So I told him, Uday, there's a problem. My patient, I think the biopsy site is infected. And he was obviously very busy, but anyway, he immediately stopped what we were doing, and he came with me, and then we looked at the biopsy site, and he also examined, and he took the ticket and wrote some antibiotic and starting temperature, everything, and he went. And that changed everything, because afterwards the patient was, very receptive and very, communicating with me, not with words, but in every other way possible, smiling and trying to tell me things and trying to understand what I was trying to ask. And, she knew I was a partner in her, progress in the ward. And I also felt very happy because I could do something useful. I could diagnose or identify a complication, and Uday was very nice. He came and he didn't just shoo me away. He came with me and he examined and he confirmed my suspicion and he gave the treatment, and that gave me, more assurance that I can diagnose, biopsy like infection. Maybe the first time I diagnosed that in my life. So that I felt very great also. And she was also, we were like partners, she, the patient and me. So it went on for a few days and she went home. I don't know what happened to her afterwards. But about several weeks later, that was a public holiday, Ramasan Day. I was at home, in my home, and the bell rang, and when I opened the door, her husband was there at the gate. And I know her husband because, she would come to see during visiting hours and we would talk also. I knew that this is her husband. And she has made some Vatalappam for me and given her husband. And, it's amazing that she was in the Ragama hospital and she's from that, I think from Kotahena area. I am from Kirulapana. I don't know how on earth they found out where I lived, but they brought the Vatalappam in a tree wheel or something. And he said her wife's name and said, she told me to give this to you, and gave the Vatalappam. It's a very, to me, a life-changing experience, because it shows to me, first of all, you don't have to be a great skilled person to help people. That's one lesson I learned. What's more important is not how much you know or how skilled you are, but what you do with the little that you know and you can do. And the people see that, people know that and understand. What they want from us is that help. At the end of the day, who are doctors? Doctors are people who are trying to help other fellow human beings who are in trouble. We are just there to help them. And why are we so special? Because we have the training with some knowledge and skills. And to me, that showed that even communication is not important. Verbal communication is not important. Even non-verbal communication can establish a rapport. And, these things transcend your language barriers. She could see my, I don't know, I would have been acting out of anxiety about being scolded by my professor more than any altruism, but still she could see that I was trying to extend and reach out and do something. And that, to me, that was a life-changing moment, because I realized that we are there to help. I realized that we don't have to have great skills. We are always worried about knowledge and skills, passing exams, a lot of knowledge, first class, second upper. That's what we are worried about, and MCQ knowledge. But actually, when it comes to the patient, that's not really what matters, but rather what you can do with the little bit you know. And also, the bond between a doctor and a patient is not something that is necessarily built on words or speech. It's something that is more human to human. And that's the language we have always known, even before we went to school or Montessori. And they can see us, our sincerity or our usefulness to them even without a common language. So that was a life-changing experience for me. And so it sort of like stuck in my mind, as a very interesting memory. So I thought I'll share that with you. It's not a narrative medicine in the sense that there's no patient narration, there's no verbal communication, but there's certainly non-verbal communication, but it brought out some good lessons for me, which, I try to remember as much as possible even now. So thank you. That's my story.
Thank you very much, sir. It is very nice story. As you said, there is no need of having a language. So as the expert committee last time also, we agreed to have this discussion in partly with their own language also. And I invite all others storytellers to use any language when it is needed in your stories. Thank you very much, sir, again. And now we are moving to next story. Our next storyteller is Dr. Lakmal Ithanage, specialist in internal medicine, Base Hospital Udugama Galle. He's one of young physician passionate with human care. Over to you, Lakmal.
Thank you, Sanjeeva, and I really appreciate for giving this opportunity, because the third panelists all are my teachers. So I'm really happy about my chance to present my case. So this patient, actually last week I saw this patient in my ward. I think, can you hear?
Yeah, you can hear.
Right.
You can hear.
Okay. She was the patient is 21-year-old girl. She presented with she was transferred from near district hospital with the history of episodes of loss of consciousness. So she was like, they suspected epilepsy and transferred. And when I saw the patient, actually she told little, and she told can't remember anything. So in the meantime, in the I told her, and the husband has seen 2 episodes. So when I spoke to the husband, I realized that the patient doesn't have features of the 2 fits. So then I suspected it. So then because of that time frame and all, and her age also, I decided better to get some psychiatric opinions. Our site is also interested in this kind of pseudo fits and doing a lot of work, and I referred to her. So around a few hours later, she called me and asked whether, do you know the story behind this girl? And I said no, because I didn't have to talk her in a busy ward round. So then the psychiatrist told me that this girl, when she was around 11 years, her mother has left the family. So this girl and her only sister, it's now say 17 years, was brought up by her own father. She's actually the poor family. So, but unfortunately, in 2020, 2 years back, some problem because of some political, her father was assaulted by some people. So where at the end he was psychiatric illness. So that's what, according to her. And then this patient, the father was in the hospital. Yeah, after this action,
You're breaking. We can't. Yeah, you're breaking. Yeah.
Of the weed. Sorry, I will little go with the story. And
Yeah,
her father,
Lakmal.
2020, after this assault, and he some change in his mind, suspected illness, admitted to psychiatric. And from there, this girl did not see the father. That means father. So then, but he was meeting there and living with her husband, own sister. So but this husband who is caring the girl and has kept the family with all this background, but they couldn't find her father. So according to the psychiatrist, this girl is having a pathological grief because of his loss of her father brought from the jail. And but the story is the patient he was present and talking a story with little smile. So depression or having multiple complaints like we see some of the patients come this stage with this kind of episodes, either chest pain, sometimes they come with the chest pains or headaches with low mood, and we can decide at the glance. So she's having some problem in the background, but this girl didn't have that. But fortunately, since I suspected her pseudofit, I thought of getting the psychiatrist's help to go into depth in the story without knowing any fact or any suspicion. So, and now the psychiatrist told that she's going to do investigation with the help of community team to search about this person, her father, whether he's alive or whether he's getting treatment in a distant place like either our Angoda hospital or somewhere as a resident. And she's going to do some research with her father's photo and some description and scanning and sending that information into those institutions. So I felt little relaxed and happy about the way that it went, which would have been missed in my practice, then sending home with some supportive care, telling that it is not fit. So that's a little story I have to tell to the panel.
Okay.
Thank you so much, Dr. Lakmal. There was some disturbances during your story. And shall we move back to our Panduka sir's story? Are there any question or comment from the audience to ask? Yes, Raghunathan sir.
So you are muted.
Yeah, can you hear me now?
Yes.
Yes, sir.
Panduka, actually, thank you very much, because there are so many young consultants are here in the audience, and there is a very big take-home point for them regarding the students. Actually, very often we take very often some of us are very harsh with them and all those things. But here, this is what you have shown is exactly what we have been trying to tell the students. Be a part of the treating team. Exactly what you have done is you have been a part of the managing team. You know, several students do that. But the thing is, because of the focus on this history, examination, and repeating people for not doing, these are often neglected. And the more and more when students are encouraged to come out with this type of thing, I think the human care will be also, this is a very wonderful story, actually, though there is again, and also you correctly said, non-verbal communication. And that exactly, that makes a lot of things, and that is how, Vedamatyas do better than us also, more than the verbal communication, even non-verbal communication, how they feel. So I think, thank you very much for the story, Panduka. It's really good for the young consultants to learn how to encourage the students to come out with this type of, because they very often you would see the best of
Can't hear.
No, that should not happen. Students being, not that I say everybody does it, but some of us actually we are very harsh on them, and they don't want to come out with their stories. Thank you.
I think
Attended in a very sweet way.
yes, Saroj sir, you have to
Yes,
comment.
yeah, thank you very much. I think the two stories show us an interesting contrasting situations, because Panduka's story, there is a story about the patient, about the issues which were there, about the nonverbal communication and so on, as well as the story of his experience. So we see, actually, there were two stories there. And I think we can learn from those two stories. Then the subsequent the subsequent story, which was mentioned by Lakmal, was again very interesting, because there he highlighted how he, from a medical point of view, he found something which didn't really fit. And therefore, he was alerted to that there might be something more. So hopefully in an ideal situation, that's where, if we have more time and if we are able to, that we might get that part of the story coming out. This, I remember a patient who was admitted with fits, and when we were able to speak to her, sometimes I get the female house officers who are a bit more time rather than the consultants who say, you build a rapport and you go and speak to them, and then they come, they speak to them, and then they realize that it was a patient who was getting assaulted at home by the husband. It was a case of domestic violence, and she was coming with episodes of syncope because of that. And of course, CTs, MRIs, EEGs have already been done. Holter monitoring, everything had been done. So I think that's a lesson from both those of narratives which we heard. Thank you. I think Ananda is waiting.
Yes, sir. Thank you very much, sir, for your valuable description on that. I think Dr. Ananda Vijayavikrama is waiting to comment on that. Yes, sir, you can comment.
Thank you very much for the opportunity. About Panduka's story, I think there is another important aspect. I think the patient quite rightly understood that it was Panduka's action which probably saved her life. If that infection was not detected in time, we don't know what complications she could have got. This highlights the importance of simple observation, which often is neglected in the ward. People tend to go behind sophisticated investigations rather than simple observation. So this highlights the importance of that. I think it is very important, not only for medical students, but for doctors also. Thank you.
Sanjeeva, can I just respond to those responses? Yes.
Yeah.
First of all, thank you for those responses. Actually, when I selected this story, I was a little worried whether some of you might think it's too simple, the kind of thing. So I'm very happy that you liked it, because you cannot relate to stories like this. They are support to all of us. Other reason why I thought of this story is because I personally believe that this quest for humaneness, which is very important, this, we are trying very hard to find this humaneness. What is this humaneness? I think it's a very simple thing. It's like getting back to basics. So, I mean, this story also reminds me of that also. At the end of the day, it was something very basic and simple, very simple human-to-human contact. So that again is a very important lesson. There's no need to do a PhD or diploma on humanness. Just, do some basic fundamental things in that you do as a doctor, and there'll be humanness there. Thank you.
Thank you so much, sir. Just my knowledge, sir, are there any particular degrees or diplomas related to medical humanities at the moment, sir?
As far as I know, there isn't, and I'm very glad that there is. Humanness is by the bedside.
Okay, sir. Thank you, sir. I think Dr. Lakmal had problem when he was telling the story. Dr. Lakmal, you are with us? Can you just summarize your presentation in one or two sentences?
So this girl presented with suspected epilepsy. I found she has her symptoms and eyewitness was not fitting with the true fit. So I referred her to the psychiatrist, and she dig into the history, and she found she had a bad experience in her life, like mother has left the family, and then she lost the father because of some father got psychiatric illness, and he was involved in a psychiatric ward, probably at Karapiti, and there he has absconded the ward. So thereafter, she didn't see the father. And according to psychiatrists, this girl is having the pathological grief about her father who looked after the family, herself and her sister. And now, because she has a, like she didn't see him, and she has the worry whether father is living or what happened to him. So now the psychiatrist is trying to find the father, if possible, through the communication with her colleagues, with having his photo and some details, and faxing it to the relevant authorities. So the message I want to like share is, this girl, even I could have missed this story simply if I know that this is not fit and giving some amitriptyline or something as usual practice in our busy schedule. And rather I thought of getting support from the psychiatrist, especially because she didn't have the low mood, or like she had a good pleasant girl and having a good talk. So that the story and the support could have been easily missed. So that's why I thought of sharing this story with the team.
Okay, thank you, Lakmal. Are there anyone to comment on that story from the audience? And anyone from the panel? Dr. Ganaka is with us.
Well, thank you, Sanjeev. I just wanted to comment on Prof. Panduka's talk. He said the one important thing: you don't need any skills or knowledge to become human. I mean, that's something we need to take very seriously. Well, as he said, just be a human to another human. That's what he did as a student. So that has been recognized as well by the patient. So that's a wonderful story, I should say. And I believe, sir, we need to practice two relationships with these patients. One, I mean, commonly taught one is doctor-patient relationship that we've been asked to practice. But on the other hand, we have to have human-to-human relationship. So if we practice that, and then these things could happen, and we could really enjoy our profession. That's something we could really enjoy our lives if we practice this human-to-human relationship. Thank you.
Thank you, Dr. Ganaka. And Lakmal's story also tell us about that rather than treating the patient as formal, what we do in the ward, we have to go extra miles and develop the patient care more. And I think it is very nice story. Thank you so much, Dr. Lakmal. Shall we move to next speaker? She is Dr. B.V. Hasheni, specialist in internal medicine, teaching hospital Karapitiya. Thank you so much, Dr. Hasheni, accepting our request on short notice. Please tell your story.
Thank you, Dr. Sanjeev, for giving this opportunity, because I do really interested in this topic. That's why I'm eagerly joining. My story also goes back to about 2 decades, more than 2 decades ago, when I was a third year medical student doing my first medical appointment. So we have just started, and somebody, I can't remember who, somebody told us, maybe our boss, Dr. Narangod at that time, told us to go and have a look at a patient who was diagnosed acromegaly, who was in the neurosurgical ward. I don't know whether I was so keen. We had just seen some patients with acromegaly pictures only, but by that time. So when I had a free time, I went to Ward 37, the neurosurgical ward, with one of my friends. And the moment we were there, the 26-year-old unmarried lady was a patient. She was not in the bed. Somebody told she was in the bathroom, and we were just going through the BHT. And in about a couple of minutes later, she approached to the bed from the foot end side, and the way she threw her towel on the bed, it was like this. Towel එක දමල ගැහුවා වගේ තමයි ඇඳ උඩට දැම්මේ. I just saw her from the corner of my eyes, she was not happy. Actually, she was annoyed. I'm sure a 26-year-old girl with obvious cause faces was not happy to be seen by the registrars, doctors, everybody in the hospital. Maybe she had been seen by so many. So while looking at the BHT, I just turned to her and said, ඔයාට කරදර කරන්නේ නැහැ. අපි ටිකට් එක විතරක් පොඩ්ඩක් බලලා යන්න. That's the exact words I said. I said, ඔයාට කරදර කරන්නේ නැහැ. අපි ටිකට් එක චුට්ටක් බලලා යන්න. Then she slowly sat down on the bed, foot end of the bed. We were on the head end looking at the BHT. And then while going through the BHT, it was mentioned that she was having hypertension, uncontrolled diabetes, and she was waiting transsphenoidal pituitary resection. Actually, for me, skull base was so complex, and the planned surgery was it was like a adventure to me. I was thinking how the hell these people are going through the transsphenoidal and reach this tumor. That was the feeling I got at that time as a poor third-year medical student. I turned to her from the, I just turned my head only towards her and asked, "Baye the inne operation ekata." Those are the few words I said, exactly same as "Baye the inne operation ekata." Just winking, I asked, "Baye the inne operation ekata." I can still picture her face, the anger and everything disappeared, and she slowly creeped toward the head end of the bed, even without getting down from the bed. She just creeped towards the bed head end and asked, "Doctor." She was from Ambalanthota or somewhere. So I was not a doctor. I was just a medical student, the poorest medical student at the third year, first medical appointment. She said, "Doctor, eka loku operation ekadda?" Then I said, "Mama ඇත්තටම දැකලා නැහැ. හැබැයි ලොකු operation එකක්. ඔයාට ඉතින් දැන් මේ තියෙන ප්‍රශ්නත් එක්ක ඔයාට ඕක කරගන්න වෙනවමනේ. දැන් මොකෝ වෙලා තියෙන්නේ දැන් සීනි කන්ට්‍රෝල් කරගන්න කෑමෙන් එහෙම පරිස්සම් වෙන්න අමාරුද?" I didn't ask a single question about her physical signs or disabilities or anything. I asked, කෑම control කරගන්න එහෙම අමාරුද? දැන් සීනි control කරගන්න නැතුව, pressure control කරගන්න නැතුව operation එකට යන්න විදියක් නැතුවනේ ඉන්නේ. She said, "Oh, doctor." Then I asked, මොකද ඉතින් මෙච්චර දවස් වෙනකන් ආවේ නැත්තේ hospital එකට? Then she said, අම්මා ලෙඩ වෙලා හිටියා doctor. මම තමයි බලාගත්තේ. අම්මත් අන්තිමට නැති වුණා. අයියලාටත් මාව hospital එකට එක්කන් එන්න උනේ නැහැ ඉතින්. එහෙම තමයි පහ උනේ කියලා. Still, we didn't ask a single question about her disease. Then she took all her photo. She knew everything what we had to see. She took her photograph from under the pillow and the x-rays, everything. And she showed me the finger. I can't put the finger and the x-rays and the heels, everything. She knew what we wanted. Still, I didn't ask a single question because I know she must have been heard up. I can't remember that I told kamak නැද්ද පෙන්නුවට. නෑ doctor කියලා. She told everything. And then I said, දැන් කොහොම හරි සීනි පොඩ්ඩක් කන්න නැතුව කෑම අඩු කරලා the little bit of things I knew by that time about controlling blood sugar and blood pressure. I just told few things which I knew. And she asked about the surgery. The things I have gathered so far, I explained with simple words which I knew. And then she was, within 2-3 minutes, she was so friendly. And then I turned to go back. The most interesting words came at that moment. Even after we turned back, she said, "මෙච්චර කට්ටිය මාව බලන්න ආවා. කවුරුවත් මට ඔය ටික කියලා දුන්නේ නැහැ." Even after 22 years, after being that incident, still every time I see a patient, I keep it in my head. මෙච්චර කට්ටිය මාව බලන්න ආවා. කවුරුවත් මට ටික ඔය ටික කියලා දුන්නේ නැහැ. I'm sure so many registrars and so many people must have come, but everybody wanted that patient's physical signs. Nobody addressed her fear, I think. I'm sure by that time I had not heard a single word. I had not even heard the word empathy, humanity. I didn't know anything. But whenever I tell the medical student, I get some opportunity to teach medical students or the juniors, I try to give this story because I also believe maybe Sir Raghunathan sir's training, I believe that stories will remember in the brain for a longer time rather than reading a book. And other thing, I tell the medical students, you don't think that you are least important. You are one of the most important team member, maybe the most important. So don't think that you are just a hanging around shadow. You be a part of it. That's the simple story. I also was thinking that this is too simple, but listening to Pandu Karunayanaka sir, I feel like yes, it changed. It echoes, and the picture of that girl still remain in my heart. Not really the brain, maybe in the heart.
Thank
Thank
you,
you.
thank you,
That's all.
thank you so much, Dr. Hasheni. It is not a simple story. It is really worth of repeating to your medical student and other colleagues. Thank you so much. Shall we ask any comment from the panels and audience? Raghunathan sir is waiting to comment for that. Raghunathan sir. Yes, sir.
Yeah.
So you are muted.
Okay.
Yes, sir.
Yeah, now we can hear.
Yeah, sorry. It's Panduka stories and Hasheni story. It is the same thing which the objectives given to the first medical appointment, both I saw in Karapitiya, Ruhuna and Colombo, are to develop the one of the objective of the first medical appointment is to develop a good patient-student relationship, which later turn out to be a good doctor-patient relationship. And Panduka and Hasheni, everyone knows how good they are. And these two stories tell that they are very early stages of their career, how the good student-patient relationship later blossomed into a good patient-doctor relationship. And I think we all, the young consultants, should keep encouraging the students on this approach to develop a good, especially the first medical appointment, because the Tamil, there's a proverb, the habit you start in the cradle will come up to symmetry. So the first medical appointment is the cradle. So I think the consultants, young consultants who are doing this student, they have a very important thing to encourage what Hasheni and Panduka has done as medical student. Thank you.
Thank you so much, sir. Shall we move to Dr. Sarath Gamanidhi Silva? Yes, sir, you are waiting.
Yeah. Sorry,
Come on.
yes. I think the humaneness develops by talking to the patient. Be a friend. I have always said in my writings also, history taking shouldn't be a question and answer session. It should be a friendly conversation with the patient that will divulge a lot of things. And actually, I would like to come in next with my story, which illustrates this, please. Okay, right.
Thank you, sir. May I invite Dr. Professor Saroj Jayasinghe, sir?
Yeah,
Can
thank you very much. Thank you very much. I think Hashini's story really highlights the process of she had used to get the patient's narrative. And that was, she didn't directly ask any questions related to medicine. She looked at the person as a human being and asked some simple open-ended questions, and then allowed the person to speak. That is, you allowed them to listen. So that's another important part in the competency, this what we call narrative competency. So she allowed the patient to express, and from that, she was able to absorb and identify what the patient wanted to know. So that's why she realized that she didn't, the patient may not be aware of her illness. So again, she was sensitive to the patient's responses, because she didn't go and ask this young patient about the facial appearance. She allowed her to speak, absorbed it, and then just asked a simple question, what about the surgery? And then the whole thing was narrated after that. And that shows how you can build a rapport and how it affects us, how it changes us as clinicians, and also how it has become a lesson to her and to all of us from that episode. And I'm sure that would have helped that patient also to go into surgery with less anxiety and with less trepidations and improve the outcomes also. So thank you very much. Thank you.
Thank you so much, sir. I think one of the doctor waiting from the USA, Dr. Mevan Wijetunga, is waiting to comment on that story. Over to you, Dr. Mevan.
Mevan, you are muted.
Oh, thank you. Thank you so much. I'm trying to turn my video on as well. First of all, I thank Professor Saroj. I randomly saw the flyer in a different forum, and this was a topic personally I was interested in. And some years ago, I think it was at the CCP, I had to give a brief talk on narrative medicine, where actually I think I started the talk with that patient Dr. Raghunathan mentioned. It was actually University of San Francisco, where they had that old lady, actually it's a woman, who was neglected by everybody. And when the residents ran out of good cases, the senior doctor kept insisting the absolutely least interesting patient in the ward should have a story. And residents didn't have anything to say. And then they approach and they keep asking, and then that story of a scar randomly, which is unrelated to her illness. This woman has been laying in that ward for days and days or weeks, had nothing else to, doctors didn't have much to offer, and she didn't have a relative. And then the scar was because something fell on her. I believe it was a trunk. And why did it fall? Because then she said, the ship tilted. That's what she said. What do you mean? The ship tilted. Why did it tilt? Well, it hit an iceberg. What is iceberg? Then everybody realized, okay, this is Titanic. So suddenly the least interesting person in the ward became the most interesting person. So that was a very highlighting story, Dr. Raghunathan. And I just have 2 points. Of course, there are so many angles we can dissect these stories. I first of all was humbled by the humbleness of all the speakers, how they approached. All of them are very accomplished physicians, but none of them alluded to the fact that the first class honors they got in whatever the context or the degrees did not matter. And in fact, I think most of them highlighted that even the medical knowledge perhaps didn't matter, except for my good friend Anand mentioned that the observational power is necessary. But even that, it's not a knowledge issue. So I think it's probably more interesting. This is once you get older in medicine and what really struck my heart was Panduka's story. What he mentioned was this was a life-changing event, and I think about a senior physician turning back and say, this was a life-changing event that you detected that mucor or purulent discharge coming from the from the kidney, and is that not that, right? So what was life-changing for a human being? And I think, all in the quest of life, we all go through the the best exam scores, then a good job and a good income, a stability in life, a family, vehicle, income. If after all that you think that's what changed your life, isn't it true? And why? And I think that's what makes us human. And I'm not saying I have the answer to that, but that's what this makes it as, you know, important with all the career goals, aspirations, dreams we pursue, but there is something we keep falling back, and that's being connected to another human being, and that change our life. So this is our moment to connect to a people as much as a teacher. We know that we always are very grateful to our teachers because they change our lives. This is our moment to do that. So it's not that biochemical knowledge that changed the life. Of course, it contributes, but that connectedness. So thank you, and it made my Sunday morning. Coming to a question somebody asked, there is actually, if somebody wants to pursue some more in-depth knowledge in narrative medicine, it was propagated by a group of people at Columbia University in New York City, and I had the interest. I can just show you a couple of books. There's a book in narrative medicine by Dr. Rita Charan. She's a, I don't know if you can see this in that, and then I have other books in narrative medicine. So there is a master's degree and master's if somebody wants to pursue, and there is also textbook with Oxford University behind. It's an interesting topic. It's never ending, just like there is no one great narrator in the world. I think until we die, we keep pursuing the perfectness in this, but the narrative part is where it becomes more important, particularly when you pursue a subject or discipline that is less inclined with patient interactions. The more procedural, more surgically oriented, the less interactions you have, so that this narration is greatly missed. Internists have a greater chance, and I guess psychiatrists have the greatest chance of elucidating this story. So thank you for enlightening us and also giving these angles that enrich us in our future lives. Thank you.
Thank you so much.
Yeah, I mean future work. Thank you.
Thank you so much, Dr. Bevan, for joining us with us. And shall we move to the next speaker? She's Dr. Lushanthi Kannangara, specialist in internal medicine, Teaching Hospital, Karapitiya. She loves to talk patient stories. Over to you, Dr. Lushanthi. Dr. Lushanthi, are you with us?
I think she has to be unmuted by the host. The host may have unmuted her.
Aslan, can you unmute Dr. Lushanthi, please?
I hope you all can hear me now. I was muted earlier. Can you all hear me?
Yes, we can hear you now. Yeah.
Thank you so much for the opportunity. And actually, it's a very good topic. And I think this is an ideal time to talk, because we need to spread these messages not only among doctors, but also we have to spread these messages to medical students as well, because as Dr. Hasheni mentioned, because medical students also have great role in not only managing or learning, but they also have a great role in especially communicating with patients. So I'm going to actually, my battery is low, so I'm going to stop my video and tell about my story. So this happened to me when I was a registrar at first year registrar, medical registrar at Colombo South Teaching Hospital. I met this girl who is, at that time she was 18-year-old. She was diagnosed with end-stage renal failure. She was only child, and her father had died when she was around 10 years of age. And her mother was also having chronic medical illnesses. She was the sole breadwinner of the family. Unfortunately, because of her illness, she couldn't go back to work, and she was on every third day dialysis. So they had a very poor support, extended family support. And most of the days she came to hospital without anything to eat, even her mother and herself. Sometimes they couldn't even find the bus fare to come to the hospital. So I met this girl, and then after talking to her mother, actually not myself, and the nurses who are in the dialysis unit, and also Kamani madam. I don't know, Kamani madam is with us now. So we all actually helped, especially we brought breakfast and lunch, homemade breakfast, lunch to her and her mother as well sometimes. And it's not only the doctors, actually, the nurses also helped to help most of the time. So now the problem was, now she was, as I said, she was on every third day dialysis. So and she was 18. So we wanted to wanted to find a donor for a kidney transplant, but they actually they didn't have financial support, and they couldn't even find, as I said, a bus fare to come to the hospital. So what one of the artists and also the doctors and the nurses who were very helpful. I want to mention that because they were really helpful, especially these dialysis unit nurses to this patient, not only the dialysis, but the prof unit ward 7. So we all got together and we advertised on a newspaper, and we talked to one of these media person, and there was this it's Lakbima, but I can remember the newspaper. This story happened in 2012. So in Lakbima newspaper, we advertise about, not advertisement, it's about a story about people who need assistance. So, and then fortunately, after seeing the artist I told, she also helped to get this paper article. So after seeing this paper article in newspaper, she found a family who helped her to get the kidney transplant in a private hospital, because their son has died due to renal failure, and they wanted to help a person who is a needy person to get a transplant. So all the expenses were done by this nice family, and she was doing very well. And then she went back to work after the transplant, after about 3-4 months. So she went back to work, and then they were living very happily. But after, again, when I came as a senior registrar to the same unit, Colombo South, and then again I met her. Unfortunately, after getting better after the transplant, she had gone to the clinic and she had taken her all medicines, but she thought now she's feeling well, and she has stopped taking all the medicines. I don't know where I had gone wrong, because I don't know whether it's our duty or it's whether we have missed something there. Unfortunately, she went into chronic rejection, and then again we had to start on dialysis. And then she was on dialysis for another about 9 to 10 months. Again, the same story. Now there's no one to help them, and they didn't have any income at all. And then mother also neglected her problems. And and then she developed infection, and unfortunately this girl who was around 20 at that time, she passed away in our ward. So then they didn't have any money to arrange a funeral. So because I personally, but I don't want, because I didn't have money, that much of money, but I personally collected money from my relatives, and also the artist I told, because I know her as well. So we all got together and we kept her body in a parlor in front of the hospital, and the ward staff, the nurses who helped, we went for the funeral and we kept that body one day there. And yeah, that was her story. And later, now the mother is alone, and mother stopped coming to the clinic. And then I had her number, and then I personally went to her house, and I got back her mother back to the hospital because her sugars were 500, 600s. Now she is not coming to the clinic. So until I went to my overseas training, I used to get her, like I call her and I get her to the clinic, and especially not only me, there were very good nurses. Still they are in a dialysis unit in Colombo South. So they used to call, and then they got her to the clinic. But unfortunately, after coming back from overseas training, I could not contact her because her number was not working. And even the nurses, I asked them what has happened to her. They have lost the contacts, and we could not find actually what has happened to her. So the story actually I wanted to tell you is, now we don't have a proper system in like we can communicate, we can personally help people, but it's unfortunate because in our country we don't have a proper system to help people who are in need. So so there are a lot of things that we can improve. It's that we have to not only like we can not helping personally, but also if we can have something, because there are a lot of stories. This is only one story. Dr. Hashini and myself are now working in Karapitiya. We daily come across a lot of patients, and it's very pathetic to see when you talk, because usually when we go to a patient's, we go and ask about, because we not only the medical problems, we talk to them and ask about their social problems, but if it's a lot, actually it's a lot. So we should actually have something after talking and after getting all these all the relevant problems, or all these information. Sometimes we are also helpless. We are also helpless. Thank you so much.
Sanjeev, you are muted.
Sorry. Thank you so much, Dr. Lushanti. Actually, you raised a concern about not having a social support in this country to support patients like that. Anyone would like to comment on that?
Well, I was hoping whether Professor Saroj Jayasinghe might want to share something on that, because to me, he's a person who has taught me about that as well. Saroj, sir? You are muted.
Yeah, sorry. Yes, I think Lushanti outlined a story in relation. Again, we see two components there. One was in relation to the patient's narration or the story of the patient and how it affected her, and then subsequently how it has once the patient, index patient, after her demise, how the mother's life was also giving us so much of educational, what should I say, making us humane because from that life story. And also the sort of the story of
how Lushanti handled it. So, which is also a learning experience for the junior physicians, senior physicians, and everybody. So that's my comment, Panduka. Thank you.
So do you want to tell us about the, the medical social services available? That's what I think Sanjeeva was keen about that.
Well, yes, the social service, I mean, we of course, Sri Lanka has a very strong informal social support system in the families and neighborhoods and all that. And then you have these, the more formal support coming from the social workers, which is they're out in the community, and there are lots of officers now in the placed within the community. I think 7 government officials per village almost, Grama Niladhari area, development officers and so on. So there is a strong network which we should tap into in such instances. And of course, we have civil society groups which help us at times of need. Again, there are several fairly well organized NGOs working in these areas. So that's the social aspect. Is that what you meant, Panduka?
Yes, I have heard that there are medical social services from the social service department. There is a person in the division secretariat and all that.
Yes.
Yes, sir, there is for this, even for this chronic kidney disease, they give a special allowance, but it was what I can remember those days, it's around 1,500 or something. Now it's 3,000, which is not sufficient at all for this, I mean, 3,000 rupees nowadays. And but for geriatric per se, actually, there is a very good system. The social services workers are there. They have these elderly homes, because in Colombo South, we used to help a lot of geriatric patients. But for young patients, only these allowances are there. But other than that, it's those are also not sufficient. But in other countries, there are these benefit systems for people who are low income, which is actually sufficient for a person to live. But here, of course, I think we need to have something more organized, I suppose.
Yes, I think there are 2 aspects to it. One is the fact that we don't have enough funds for a huge cash transfer like that. And we have had these discussions going on between the Ministry of Health and the Ministry of Social Services for quite some time. Initially, we made this proposal to have social workers placed in the hospitals way back in 2015. And there have been several rounds of discussion, but it has still not worked out, because now in such instances that you faced, it would have been very easy if there was someone in the hospital itself who could have taken over this coordination role and tried to find out about what sort of support is required, what sort of support is available, and so on. So that's hopefully things will improve if these are implemented. Yeah. Thank you.
Thank you very much, sir. Now we are moving to next speaker. It is honor and privilege to introduce him, Dr. Sarath Gamanida Silva, Senior Consultant Physician in General Medicine, past President of Ceylon College of Physicians. He was a great teacher, researcher, and writer and editor to many journals and articles. Please listen to one of his patient story. Over to you, sir.
Thank you. Thank you for inviting me. And in fact, after you all started the session, I have changed my story. Earlier, I said it's some administrative matter, but I think on this humaneness, as I said, it's a matter of actually starting a conversation with the patient. And that conversation, which should not be a question answer session, but it should be a friendly conversation with showing genuine interest in the affairs of the patient. Actually, these stories, if, I'll tell you, there was a middle-aged lady who came with all the possible complaints, headache, chest pain, insomnia, everything. And it sounded like a functional illness, what we call psychosomatic or functional, because none of those symptoms are specific. The chest pain was non-specific, headache was non-specific, and with further questioning. Mind you, all this happened within a matter of 5 or 6 minutes. because one answer should lead to another question. That's how I look at it. And it turned out that this middle-aged lady had her youngest daughter at home unmarried, and that is what caused all her anxiety. And she had no other problems whatsoever. So I avoided doing all the unnecessary investigations about the chest pain or the headache. I reassured her and gave some simple symptomatic treatment. I sent her off. 3-4 months later, her husband came for some other matter and said that she is quite well now. In fact, her daughter, they have found a partner for the daughter, and she was going to get married in a month's time. This was about 6 months after I first met her. Lo and behold, another 6 months later, altogether 1 year later, she comes back to see me with the same story now. Again, headache, chest pain, insomnia, all that. I was just wondering whether I have missed something. But further questioning showed that now that the youngest daughter got married and wed, she is feeling alone at home. So that was the reason for this second episode of anxiety and depression. So unless I went into her details, I wouldn't have detected that. Of course, again, I had to reassure, and with time, of course, she got better. That was one other thing. And then another thing we have to keep in mind is retirement. Either retirement or impending retirement can cause a lot of anxiety among our patients, which of course, again, they come with all kinds of non-specific symptoms. Unless you ask about their social setup, about their job and all that, this won't come up. You know, this, I think he was about 65 years old, retired headmaster. He retired about 5 years earlier, and now he is presenting with alcoholic cirrhosis. In fact, he died in the ward. But initially, when the case was diagnosed, the wife came and said, see what happened to this man. He never touched a drop of alcohol until retirement. From the first week after retirement, he started drinking. And now he has developed alcoholic cirrhosis in a few years' time. So they were really, really sad, because this retirement, again, was an unplanned one. You know, teachers are bosses in their schools with a lot of people under their control. And suddenly when they lose that, they lose their direction altogether and get into difficulties. A third case I will just say, that is the last one, was another man about 50 years of age, I think, came with a chronic cough. So he was coming several times, and he was supposed to be bringing out some sputum also. I did all the investigations, and no, everything was negative. So it was mainly symptomatic treatment. And then on the third or fourth visit, the wife told me, this man is worried because he's going to lose his job within a month or two, because the company he was working for was closing down. And then this lady said she's coughing mostly at night. He couldn't sleep. So I reassured him again. I never thought that it could be due to that, losing employment, giving a cough. But then a few months later, again they came. He has found another job, and his cough has disappeared. So talking to patients can bring up so many issues that could have a direct relationship to the illness. And if you don't get those details, one would end up with all kinds of detailed investigation, expensive investigation, which could easily be avoided if you talk to the patient. That's all I have to tell you.
Thank you so much, sir. Anyone who wish to comment on those stories? Actually, there was a problem with voice also, I think. Anyone who wish to comment on?
Can't hear.
Yes, anyone? Thank you very
Can't
much,
hear,
sir.
please.
Yes, thank you very much, sir. Anyone who wish to comment on those stories from the panel, Ganaka?
And if he's talking, we can't hear.
Yes, Dr. Purnima Pereira is waiting to comment on that. Dr. Purnima,
Sorry, I can't hear.
sir. Can you hear me? Yeah?
I'm sorry, I can't hear anything.
Yes, sir. Can you hear?
Silent.
Yes, Dr. Purnima Pereira is waiting to comment on those
Sorry, I can't
stories.
hear anything. Trying to put things right, I don't know.
Purnima has to be unmuted.
Thank you. It's a wonderful presentation. I like to say all the presentations were about the almost all the presentations were based on the
I
narratives.
can't hear anything.
Seriously,
Sorry. Yes.
Doctor, can you
I
hear
think-
me?
Yes, yeah,
I
we can
think-
hear.
I
We
think
can hear
Sarat
you. Hear me,
Gamini, yeah, I think Sarat Gamini has knocked off his earphones.
I
Can
can't
others
hear
hear me?
anything.
Yeah, I think better tell him. Can someone give a call and tell him?
Yeah.
Doctor, this is not particularly about Dr. Sarat Gamini's presentation. I'm a lay
Yeah.
person. I'm not a medical person. I'm a non-medical lay person. Maybe
Yes.
as a patient, I'm talking to you because this is a publicly shared Zoom link. So I just logged in.
Exactly.
I think it's fine. It's fine to comment on.
Yeah, comment.
Almost all the presentations were based on the narratives of resident patients in
Sir, why don't you switch off your video and try and see? We can hear when you talk.
Yes, Purnima. You can talk.
Can I continue?
Yeah, yeah.
Yes.
Yes.
Only now I
So-
started the screen. Sorry.
So the presentations were basically based on the narratives of the patients who were resident in state sector hospitals, and most of the presentations are based on memories, either the life-changing stories of patients, how your involvement, having listening to them, have changed their lives or treatment, or have improved the quality of treatment, or mind-changing, how having listened to the patient stories have changed the way you look at the importance of talking to patients, which is great. But I was waiting to hear. It's not reasonable to expect to hear what I want to listen to. But patients are patients, whether they go to private sector or state sector hospitals. It would have been very interesting if there were narratives from both private sector and state sector hospitals. From my experience, the only place where doctors listen to patients in detail is R3 Medical OPD, where there are very senior female doctors, retired doctors who spend time listening to people. If you go to the private channeling places, doctors usually, I've never been listened to more than 5 to 10 minutes time. So where the limits occur? Listening to patients' narratives is important, whether it is OPD or resident. So I'm just asking your opinion. I think it would have been helpful to understand or analyze the importance, limitations, or practicalities of developing, giving prominence to taking human narratives. Just a personal opinion, lay perspective.
Thank you so much, Purnima. I think our expert panel will comment on those your concerns. May I move to Dr. Lakmal? He is waiting to comment. Dr. Lakmal.
Yes, Sanjeev, yes. Actually, I wanted to comment on Dr. Sarath Gamini's patients. Actually, thank you, sir. And it is the common scenario that we are seeing in our wards also nowadays. And we are seeing many patients after a lot of investigations coming again and again admitting with the complaints, non-specific complaints. And at the last moment only, we thought we are thinking about this, whether they are having some functional issues. So that's the mistake I think we are making at some point. And then we ask, or we refer to psychiatrists and then coming up with stories. Actually, we get to know the things in the ward. Sometimes nurses help. They say patients is not talking or not moving and not taking medications. And then only we start to think whether she has some depression or anxiety or something else. So I think that talking to them, and whenever we give them the opportunity to talk, they come out with stories that sometimes we feel very pathetic and helpless. So very important things, and we are daily seeing these kind of things in wards. Thank you.
Thank you so much, Dr. Lakmal. Dr. Bandusiri is also waiting to comment something. Dr. Bandusiri. Yes, Dr. Bandusiri. Over to you.
Bandusiri, you are muted. I wonder whether he's trying to unmute himself just like Dushanti was trying earlier.
Yes, we will see that. Until such time, may I invite Dr. Saroj, Professor Saroj Jayasinghe is also waiting to comment on stories.
Yes, thank you very much. And thank you once again, Purnima, for giving your point of view. I think it's very useful and very important for all of us, because I think you have to see this as an initiative which we are doing. And if you listen to the initial presentations, this idea of, we have always been teaching students and all of us have been taught to listen to patients, give them time and speak to patients kindly and so on. So this needs separate, now what we are trying to do is to really bring this to the fore of the professional colleges also, and to enrich the way we teach our students, and hopefully try and get our physicians also to improve on their work. So your points are well taken, and this is a process which has started, and hopefully there be more converts to this sort of way of looking at things and learning from patients, learning from their stories and being sensitive to their stories, because the experienced clinicians know that being sensitive to the human angle of patients is the crucial part of your alliance or whatever with the patient. Yeah. Thank you.
Sanjeev, you are muted. Sanjeev.
Thank you so much, sir, your comment. Now we are moving to the next speaker, Dr. Kisri Karunatilaka, physician in healthcare, older people, William Harvey Hospital, East Kent Hospital, University Foundation Trust, Kent, UK. Thank you so much, Dr. Kisri, accepting our request on short notice. Over to you, Kisri.
Thank you, sir. Can you hear me, Sanjeev?
Yeah, we can hear.
Oh. Thank you very much for College of Internal Medicine and the President, my dear friend Ganaka, for inviting me. And I feel humbled to present in this forum. I just thought I have a lot of experiences in Sri Lanka, but I thought I would present something that I experienced here. It's about a patient, actually, still I currently I'm looking after. Patient is 85-year-old female who came to my ward about a week ago with a history of fall, and she had a fractured pubic rami on her left side, both pubic rami fractured. But orthopedic doctors have said she can be mobilized as her pain allows, so she remains there. So the physiotherapists have assessed, and then we are trying to sort out her discharge. So this lady was admitted again another week ago to our hospital, and she was discharged again with a fall. So this is the second time she was admitted. However, she was there in the ward. She has a background of atrial fibrillation, congestive cardiac failure with ejection fraction of 15%. This was 2020, 2 years ago. She has got dementia, mild to moderate. So this frail lady, very small, frail lady, lives with her husband. Husband is also 90 years. And then she has carers to look after her twice a day. So frail lady. And on the day 5, she suddenly started getting breathless. So knowing that she has got congestive heart failure, and she developed a bit of a temperature spike, and we did a chest x-ray showing that she has developed a pneumonia. So she being in 5 days in hospital, so we thought she developed now hospital acquired pneumonia. Her swallowing was okay, so I didn't think that it was aspiration. And on top of that, she developed features of worsening heart failure. So she required oxygen. We put up on some oxygen, and I felt that she might deteriorate. So it's very important to understand if the patient is deteriorating as well. So my impression was, okay, let's treat her with chest infection, knowing that she's very frail. She's 85. Let's treat her for next 24, 48 hours and see. So following day, she looked much worse. And I thought she's declining very rapidly. So she was very drowsy, couldn't arouse her, and very sleepy, very dry, not eating and drinking now. So on oxygen, not making any communication at all. So I thought I would speak to family and then make a decision of end of life. Felt rather too quick, but I felt this lady with ejection fraction of 15%, very unlikely to recover, and very high mortality. So spoke to family, husband was there, son was there, and I explained everything I thought she's not going to recover. And they asked me, what's the prognosis? I said, I think it probably will be days rather than weeks. So they were upset, they were sad, and we made end of life decision, and we made the paperwork. So they were allowed to come and stay with her. So husband, this poor husband who could not actually even walk very properly, stayed by her bedside overnight. And son told me that no, actually the problem is with the father, because he can't take him away. He doesn't leave the place because they've been married for 70 years. So we left her like that. Second day I went to see her with my junior doctor to see that she had a bit of a good color. She was still on oxygen and the family was around. So then I spoke to her. How are you? She suddenly opened her eyes and said, I'm fine. Now, this is a lady, I put her on end of life yesterday. So I was a bit surprised, but on the other hand, not as well. So, and then I asked about from the family, how is she? Oh, she's talking. She had her breakfast. Okay. So then I asked the lady, patient, have you had your breakfast? Yes, doctor, I just had my toast and jam. That's very good. So you're doing much better. Yes, yes. I remember you seeing me yesterday, she said. I don't know if that was actually true, but she was very drowsy yesterday. Then next question she asked me, doctor, have you had anything for your breakfast? I felt a bit, shocked and, embarrassed as well. So this is the lady, I will put her on end of life yesterday asking me, have you had your breakfast? Then, so you can understand how embarrassed you are in front of the family. And moral of my story is like, patients can make you look stupid. So then I had to have another discussion with the family. Now, it lies on a lot of other communication things that we have to discuss with the patients and relatives, and about how we will be looking after these patients when we have made end-of-life decision and a lot of complex issues that you have to address. But I think I will leave it there and then leave the discussion open so that I can explain if there's anything further. Thank you.
Thank you so much, Dr. Kitsri. I think after another 1 or 2 stories, we can have a story comment on those stories. Shall we move to next storyteller? He is Dr. Sahan Mendis, lecturer, Department of Pharmacology, Faculty of Medicine, Ruhuna, specialist in internal medicine. He is acting consultant to Teaching Hospital, Karapitiya. Over to you, Dr. Sahan.
Thank you, sir. Am I audible?
Yeah, we can hear you.
So I must thank SLCIM for giving me this opportunity. I must say that really I'm not the acting consultant, sir. I'm working as a lecturer in pharmacology, Department of Pharmacology, Faculty of Medicine, University of Ruhuna. Since I'm attached to the university, I'm working there till I go for my overseas training. Thank you for your kind introduction, sir. And so initially I was thinking about a different story of the peer relationships. But when I was listening to the stories here by the expert storytellers, I thought I should actually change my story as well. And I think I am the least experienced storyteller, the narrator among all storytellers here. But still I have some stories to tell. So just let me unveil my story. So this is regarding a 43-year-old gentleman, a man, a father of 2 children, who was previously healthy. This man was transferred to Teaching Hospital, Karapitiya from a distant hospital. And when he came, he was deeply icteric, and he was frail and he was wasted, but he was all right. I mean, he was happy, and he was talking to his relatives, even the medical students, because this is a professorial unit that I work at Teaching Hospital, Karapitiya, and he was very friendly with the medical students, but he has deep icterus. And also he was found to have these nice and fascinating clinical signs. When I say nice and fascinating, I would like to say it is within inverted commas, like nice and fascinating clinical signs, such as hard nodular liver, which is easily palpable, and the fascinating rare clinical sign, which is hepatic bruit. So the medical students were very enthusiastic and keen to examine this patient, who was very helpful, very cooperative, and even the medical registrars, I as a senior registrar, with his kind permission, took class on examination of the abdomen with a bedside class with this patient. So he was very helpful to all staff members, as well as the medical students. But we were keep investigating, and it was obvious to us that he had a tentative diagnosis of hepatocellular carcinoma, and he underwent, he had a ultrasound scan abdomen when he came to the ward, which revealed possible hepatocellular carcinoma. So he underwent a CCT abdomen, which confirmed that he has hepatocellular carcinoma. And since the diagnosis was made, we sent him to the oncologist to see. And from the day he was sent to oncologist, he came back to the ward, and from there the situation changed. He was so thoughtful, and he was not as helpful as he was earlier, and he was really furious at medical students who were approaching to help, who were approaching to examine him. And during our busy ward rounds, we realized that he was not normal. He was refusing his meals, and he was so upset. So we thought he was suffering from depression, and we referred him to a psychiatrist, and psychiatrist has started antidepressants, and he has given the psychological support for him. But when on our advice, his family members came to see him. Now we had to keep him for some other reason. We had to keep him for another 2-3 days. And when he was, the family members, especially his brother, the younger brother, came to be with him. And the one fine night, when his brother has gone to washroom, I think his brother has asked the other bystanders to keep an eye on him. But unfortunately, suddenly we heard a noise from the back end of the ward, and he has jumped out of the ward. That was the ward was in the first floor, and he has jumped out. And then the ETU was not close to the ward, so we had close to the place where he was fallen, and when we had to bring him back to the ward, and we tried to resuscitate him, but unfortunately he passed away. This 43-year-old man, father of 2 young kids, passed away. I think we were really shocked to experience this, and because we knew him very well from the first day he came to the ward, and we were wondering what has made this pathetic situation. What was wrong in us? I think still I'm confused, and we are in dilemma. How could we acted better in this situation? How could we avoid him? Some would say that he is anyway in a terminal illness, that this is his fate. But as doctors, what was our duty? I'm actually confessing that we have missed something. That's why we missed this valuable patient. Thank you. I think the expert panel and the distinguished audience will help me to solve this question. Thank you.
Thank you so much, Dr. Sahan. Shall we move to our panel? I hope panel will have a comment on both stories already said, Dr. Kisri and you, Dr. Sahan.
Shall I go ahead, Sanjeevan?
Yes, sir.
Okay, right. So thank you for both these stories. So Sahan, that was a very, how shall I say it, very intriguing story that you shared with us. I don't know, I can't make a diagnosis from this chair, obviously. But what I felt when I was listening to how the story was narrating was whether at some point he received a certain shocking news which he couldn't bear, and that caused the change in his the way that he was behaving. maybe he was having either a lack of awareness of the diagnosis before that, or maybe he was having a lot of optimism before that, which after the consultation outside your unit may have turned into a sudden turnaround and a lot of pessimism, or a feeling of loss of hope, and then that may have that can work in several ways. For example, it will be some problem for him, and the way that he relates to you will also change, because he might think you didn't share that part of the information with him before, the fact that it is hopeless or something like that. So maybe that's what brought that. So I may be wrong, I may be completely wrong about it. I'm just sort of imagining what must have been happening. So if it is what was happening, then I suppose this brings out the importance of communication skills, of giving serious news in a very careful way, and preparing them for that. And so I mean, that's a very important lesson for us. I actually in a private hospital in Colombo where I was working, also I heard a similar situation where soon after the consultant had shared the diagnosis of cancer and gone out, he had jumped out of the window from a very tall building and he died. So the process of telling patients the diagnosis must be very carefully done, I suppose. I don't know exactly how to do it. I mean, of course, we read these things in books about the Breaking Bad news and all those things. But in Sri Lanka, I suppose we have to maybe discover our own best method of breaking bad news. I think it's important to make the family a partner in that process, rather than worry too much about the sort of autonomy that we talk about in medical ethics in medical school, because our autonomy is very different. It's more shared. So therefore, we can involve the patient also in that discussion, and that will ease the problem a lot. And by making use of the patient's network, social network, to absorb the shock, as it were. So anyway, that's my thought when I was listening to your story. To me, it brought out the importance of careful communication. And the other thing that when I was listening to Kit Siri, another interesting, I mean, you said she asked you, have you had your breakfast? I had a similar experience when I was in England. It was a post-take ward round, and there was this old gentleman with COPD doing very badly and needed, maybe intubation, ICU bed to reverse the process. But then you can't find ICU bed because there are competing patients for that. And I am the registrar who has to tell the patient you won't be getting an ICU bed. So, with great trepidation, I went to this old man and had a little, chat with him, gave a few firing shots, and then said, you might not get an ICU bed. So, in the typical British, informal or indirect way, without saying you won't get ICU bed, it's not likely that you might get a bed right now. That sort of, I put it like that, and immediately he said, "Oh no! Don't find a ICU bed for me. I'm 80 odd years old. I've lived my life. It'll be a shame if you give the bed to me. Give it to some young man." I have never heard that sort of attitude in a Sri Lankan patient. I don't know. I mean, those two cultures are so different. I don't know why. They maybe because they have a good life. In any case, and they are prepared for a good death thereafter. Maybe our patients live a life of suffering much more, and it's an endless suffering. And for them, they can't imagine a good death after a long suffering life. I don't know. It's just a very amateurish thought that I shared with you, but. I feel that those patients coming from that culture are very different to our patients. Here we would want to grab the ICU bed for myself, but there he said, don't give it to me. Don't be silly, give it to a young person. That shocked me. So anyway, thanks for your stories.
Yeah, I think just think about when I was reading a book about this, I felt, thank you very much, Panduka sir, about the comment. Now, I think, yeah, I totally agree. It's two different cultures. I think the difference is probably, I think, being a developed country, they are very content with what they have and they have enjoyed their life. So later on the life, I think they have given up their responsibilities and they're just mostly actually living alone. And then sometimes I feel that actually they are really fed up with continuing their life. So that may be one reason, oh, we had a good life, we had a lot of enjoyment, and then just let it go now. So that probably is, but I think in our context, in our culture in Sri Lanka, so we are still, even our older parents are with responsibilities for their children and their children's children, and then so this goes on. So their responsibilities are not over. So I think that may be the difference, and it probably goes into a probably scarcity principle, which always is executed in the society. And because these people have a lot of resources abundant, they are not really worried about it. But in our country, our resources are very limited, scarce. So we tend to look for more and then grab more and then things like that. And that explains the current situation as well, I think. Thank you.
Okay, thank you, Kitsri, and thank you, Dr. Professor Panduka Karunanayaka. Shall we move to the next story? Actually, this story will be told by our president, Sri Lanka College of Internal Medicine. Dr. Ganaka Senaratne will talk on another story. Over to you, Dr. Ganaka.
Thank you, Sanjay. I think we have passed our 2-hour period, but I can still see people are having enthusiasm to listen. I will try to make it very, very short. Well, this is an experience. This will be the last story, I believe. Experience from Ellavaya, my first appointment. There was a lady in the ward, about 85, 90, whom I've been treating as a pneumonia. I tried with a lot of drugs and changed to meropenem at the end, and she developed septic shock, and because of her mobility issues and other comorbidities, we decided not to put her on ICU. Had a discussion as what Kistri did with the family. They all agreed for a DNAR and to keep her in comfortable position. So she died the next day, and then after that, I generally take the family into my room and sort of try to have a explain. So I said, well, we as a team, we've been trying hard to cure her, but it didn't work. I can understand your feelings. If I say in the words that I said, මට තේරෙනවා ඔයගොල්ලෝගේ කනගාටුව දුක. අපිත් ස්පිරිතාලයක් විදියට ටීම් එකක් විදියට අපිත් ඔයගොල්ලෝගේ දුකට සහ කනගාටුවට එකතු වෙනවා. අපිත් ඒකේ කොටස්කාරයෝ කියලා. So I said to this party. So there was an elderly gentleman who was been staring at me for about a minute, and he started speaking. Said, Doctor, අපි දැන් අවුරුදු 60ක් විතර වැල්ලවායට ඇවිල්ලා මම මේ ඉස්කෝල දෙකක ප්‍රින්සිපල් වෙලා ඉඳලා තියෙනවා. ගොඩක් අපේ ඥාතීන් ආවා ස්පිරිතාලෙට, සමහරු මැරුණා. හැබැයි මේ පළවෙනි වතාව තමයි ස්පිරිතාලේ අපේ මරණයකට අපිත් එක්ක කනගාටු වෙන්නේ. So that's what he said. So that stuck in my mind. Well, we see a lot of people dying, but death is something very common to us. It's a death for us, but the death for that family or the person, it's very unique. So that's the story I had in my mind. Well, thank you, Sanjeev. That's it.
Thank you so much, Dr. Ganaka. I see Professor Saroj sir is waiting to comment on those stories. Saroj sir.
Yes, thank you very much. I think, Ganaka's story was, that's a very important story for all of us. And if you looked at the stories which were discussed today, we are seeing two forms of narration. One is the narratives by the physicians themselves of what they experienced. And also we had Pumi who narrated her story. And that's one aspect of it. But within these, embedded in this, are the narratives of patients. So we can learn from both, because from the physician's story, we understand and we see some of the trials and trepidations we have, the anxieties we face, and how people have tackled those. But in narrative medicine, there is a larger focus on the patient's story and learning from the patient's story. And that's where, if you looked at all the stories which about the patients, you see glimpses of how you get that narrative competence, in the sense of how do you get that story. It could be the one, the way Hashini, no, sorry. Yeah, I always mix up with Hashini. Yeah, where she showed how a few open-ended questions help to get the communication going, and how she allowed people to listen. And in a similar way, the final story by Ganaka also brought out that how he gave them that opportunity, and he noticed someone was wanting to speak and gave that opportunity to speak out, and how that person came out with the story, which was so revealing. And so touching. I get reminded of one of the students who came and said, so the most important thing I learned was when I went to the ward for the first time, if I smiled at the patient, I got such a good response. And after that, every day the patient used to say, because you are smiling, we feel like speaking to you. So I think we are slowly getting into the narrative competencies, or how we should get stories, listen to these stories, and try to process them and respond appropriately. So thank you very much once again. I think this has been a wonderful session, and over to the others. There are several other hands which are up to speak. Thank you.
Thank you so much, sir. Shall we, yeah, we can allow one or two comments. Raghunathan sir is awaiting to comment on. Over to you, sir.
Thank you very much for all those wonderful stories. And Ganaka brought a being the president of SLCIM, he brought a very important thing, which I was, one of the stories which I wanted to do and dropped it. He brought it about what we are not doing when patients die. This happened the day before I retired. The day before I retired, and I went to the ward in the morning. In the reception session, there is a girl weeping very loudly, very loudly, and there were more than SR, 2 SRs, registrars, HOs, medical students, all of them were there. So this girl is screaming and shouting. So I knew someone must have died. And I just went to actually, this is something which I confess, actually, at the end of my career, this is something which I learned on the day before I retired. So when I went and asked, what is this girl crying? And the answer was, sir, ara Kopalmanale Hamadama Vodekata repeated admission, ara Kopalmanale Leda, sir. This is what is happening. Why cannot, when somebody is shouting someone has died, why can't one of the team member, this is not, I'm criticizing my unit only, this has happened in every unit where this happened. And I think Ganaka, this is something which the college can, CCP and everything, a bereavement process. In the other countries, when somebody dies, there is a process of bereavement. Even the priests, there are priests, if it is a Buddhist patient died, a Buddhist priest can be brought in and thing. And also, the empathy, if these people who are there, not that I'm blaming my own team, but sometimes this doesn't, we think, okay, this is for us, this is a known person who had several admission co-pulmonale. So I don't blame, but the thing is, why cannot one of them come and sit with the patient and explain to them, okay, you have tried your best and we have done our best, and this is which settles the patient. So I think after all these stories, though this is a bit different, I think this is something the colleges should take. How do we respond to bereavement in the patient dies? I think this is not happening in most of the units, most of the hospitals, and someone should take up this and do this. I think this is something, though not related to the narrative of the story, which is a good thing. And after all this is about bringing humanness, and humanness does not finish when a patient dies. It also sometimes starts with the relatives, with the people who are bereaving, and I think we need to look into it. Thank you.
Thank you so much, sir. Hasheni, you can be given 1 or 2 minutes. You have to unmute. Hasheni?
Yeah, regarding when I heard Sahan's story, I should emphasize that there is a in between. This is a teamwork, and in between, I feel like when I communicate with our patients and other team members also, I don't know, maybe because of lack of knowledge about diseases and all, especially the junior staff, sometimes things can go totally wrong. I'll give a small example briefly. There was a patient which I went to examine during one of my exams. I think it was a patient, female patient with a differential ascites, and I just went to do the abdominal examination. But the moment I went there, I saw that she wasn't looking happy. She was depressed. I asked me, "Ayame hitte amaruwen wage asanipe nisada?" Nෑ nona ඊයේ තාසිම් එකට එක්කන් ගියා යන වෙලාවේ ඇම්බුලන්ස් එකේ ගියපු මිස් or somebody මම හිතන්නේ junior staff member අහක බලාගෙන යන්න කිව්වා ඔයාට TB තියෙනවා කියලා. I think it says a big story. And there was another young girl with diabetes, senior, when I was doing the senior registrar period. She was always coming to me in the clinic, and her appearance wasn't very happy. One day I asked from our our famous attendant in the clinic, I asked මොකෝද අර මේ ටිකක් upset එකේ වගේ නේද හිටියේ. When I asked her, the patient was not talking. මම ඇහුවා ඇයි මේ කියනකොටම the attendant always with us said දවසක් වාට්ටුවේ මම හිතන්නේ DK වගේ හැදිලා ඉන්න වෙලාවක somebody has told her කසාද නම් බඳින්න එපා බැන්දොත් අමාරුවේ වැටෙන්න වෙන්නේ මහත්තයාට. These things happen in between. It can totally change the thing. I had to take another half an hour to explain the girl why we are doing all these things to keep a normal, near normal life. So this is I just wanted to add this. Thank you.
Thank you so much, Hasheni. I think one of the doctor from the Vellava is waiting to comment. Dr. Manjula Appa. Yes, Manjula Appa. Manjula.
Can we mute Manjula, unmute Manjula, Sanjeeva?
Yes, that should be done by, yeah.
Aslan.
Yes, good evening, everybody. I'm Dr. Manjula, MOH Vellava. I was the acting MS in Vellava base hospital when Ganaka sir there in the VP. So I have a very lot stories to tell with Ganaka sir. Whatever it is, just to comment that we as community doctors, we see as many of doctors and consultants have all they saying that this social support from the patient care. දැන් සර් දැන් ඒ ගොඩක් වෙලාවල් වලදී සර්ලා කතා කරපු එක දැන් අපිට ගණක සර්ලා මෙහෙ වැඩ කරද්දී අපි දැක්ක දෙයක් තමයි ටීම් වර්ක් එකක් team work කියන work එක ඇතුලේ hospital curative sector එකේ team work එක complicate වුණාට patient discharge කරලා යනවා asymptomatic treatments දීලා ගෙදරට ගියාට ඒ patient totally cured වෙන්නේ නැහැ. ඒ community එකට ඒක hand over වෙන ප්‍රමාණය අඩුයි කියලා අපි හිතනවා. කියන්නේ දැන් ගොඩක් හැම patient කෙනෙක්ගේම තියෙන social problem ටික අපිට curative sector එකේ sort out නොවුනට social එකට hand over වෙනම නම් අපි emotional විදියට enough social workers ලා ඉන්නවා society එකේ AGA, PHM, PHI many කියන අපේ government sector එකේ ගොඩක් අය ඉන්නවා. ඒ අපිට මේ curative sector එකත් preventive sector එකයි social work එකේ හොඳ communication barrier එක නැතුව communicate වෙනවා නම් මට හිතෙනවා දැන් ඔය ගොඩක් කතා කරපු දේවල් ඇතුලේ අපි කතා කරන ගොඩක් දේවල් hospital එක ඇතුලේ විසඳන්න බෑ. ඒවා යම් විදියකට අපි ඒකට හොඳ curative sector එකයි social preventive sector එකයි barrier එක හොඳට පාලනයක් කරන්න පුළුවන් MOH එකට. දැන් ගොඩක් අයට MOH එකයි hospital එකයි ලොකු barrier එකක්. කියන්නේ අපිත් එක්ක communicate වෙන්නේ නැහැ. මම ගණකස අපිත් එක්ක ඉන්න කාලේ ගොඩක් වෙලාවට දැන් අපි MOH එකට කතා කරනවා, ප්‍රාදේශීය කන්තුමාට කතා කරනවා, social workers වලට කතා කරනවා, PHM වලට කතා කරලා patient hand over කරලා feedback එකක් ගන්න එක. කියන්නේ that team එකට include කරගන්න ඕන social workers සහ ඒ team එක. දැන් ගොඩක් වෙලාවට ඒ කතන්දරේ අපි අහුම්කම් දුන්නට social problem list කරාට curative sector එකේ රෝගයට ප්‍රතිකාර කරලා ගියාට ලෙඩා රැගෙන යනවා. තව ගොඩක් ප්‍රශ්න ටිකක් අපි අහුම්කම් දීලා ඒකට උත්තරයක් නැතුව සමහරවිට ලොකු ප්‍රශ්න ටිකක් තියෙනවා patient. ඉතින් ඒක නිසා මේ අපි විශේෂයෙන්ම අලුතෙන් එන doctors වලට medicals වලට දැන් එළියේ තව team එකක් ඉන්නවා cases එක hand over කරන්න. ඒක take over කරන්න පුරුසුකුත් ඉන්නවා. මේ message එක අපිට පොඩ්ඩක් hand over කරගන්න තිබුණා හොඳයි කියලා හිතනවා සර්. මම හිතන්නේ අපි ගණක සර් ඉන්න කාලේ අපි ගොඩක් පැල්ලවයි වගේ වැඩ කරා. Lot more story to tell, but this is not the time. I think very time limited. So thank you very much for giving, and Ganaka sir, thank you very much for giving me a good opportunity for this.
Thank you so much, Manjula. Would you like to comment, Saroj sir?
Yes, thank you very much. I mean, that was very, very interesting and very revealing, because the support system which is outside, which is there in the community, and I think if you are thinking of helping our patients, we should be linking the social services to the health sector in a closer way, in a closer manner. And one proposal has been, again for several years, is to try and get these medical social workers either from the Ministry of Health or place some of the social workers from the Ministry of Social Services in the hospitals. So I think that's the way forward. And and of course, medical students are you know how these connections can be made and how we are able to help these patients, what comes out of the narration and what sort of problems they have, that we really can help them if we link up with the services which are available, as well as their own relatives and family network, the informal sector networks, and whatever community resources which are available. Yeah, thank you.
Thank you so much. Dr. Kisi, you want to tell something?
Thank you very much. Mama හිතන්නේ අත this is a very good session. මම totally agree වෙනවා මේ රඝුනාදන් සර් අතරම කියපු දෙයට. මේ මොකද ඒක අර policy making එකකට යන්න පුළුවන් නම් ඇත්තටම මේ කරපු discussion සහ future discussions ඒවා minute වෙලා ඒවා policy decisions විදිහට මේවා තමයි defects මේවා තමයි ඉස්සරහට වෙන්න ඕනේ කියන එක policy decision එකකට ගිහිල්ලා ඒක implement කරන්න පුළුවන් නම් that's the very best that we college can do. And again, Dr. Appar community එකෙන් දීපු suggestions අනුව that there is very good support system ඒවත් එක link කරන්න පුළුවන්, and that's the very best that college can do. I think all the best. Thank you very much for organizing this.
Thank you so much, Dr. Kitsri. I think we are coming to the last part of this program. We had 2.5 hours discussion about the human care. Now we are going to conclude our program. Next vote of 10 that will be done by me on behalf of Sri Lanka College of Internal Medicine. and expert committee of humane care, I would like to first thank to the expert panel of the discussion, Professor Saroj Jayasinghe, Professor Panduka Karunanayaka, and Dr. M.K. Raghunathan, and President Sri Lanka College of Internal Medicine, Dr. Ganaka Senaratne. Their advices and guidance were really helpful to have this session successful. Thank you so much, sir. Then I must thank Dr. Yes. Can you hear me?
Yeah, we can. That was.
Yeah. Thank you, sir. Then I must thank Dr. Sarath Gamini Silva, senior consultant, who accepted our request on short notice. Thank you very much, sir. Further, I must thank rest of the storytellers, dear colleagues, Dr. Lakmal, Dr. Hasheni, Dr. Kisri, Dr. Lushanti, and Dr. Sahan for their contribution, which made this program successful. And then I must thank Mr. Kamaladasan and Mr. Paslan for sponsoring this program and giving their technical support. Thank you very much, Dr. Kamaladasan and Dr. Paslan. At last but not least, I would like to thank all the participants for this program, and they spent more than 2.5 hours with us and sharing their valuable thought. I hope we had a good, great day today. With hope of having similar program in the future, we will conclude program here. Dr. Ganaka, anything you want to tell?
No, Sanjay, that's it.
Thank you very much.
I'm really happy that people have been waiting until then. And I believe that we tried our level best to sort of popularize this compassionate and empathic care. We'll be trying our level best to do so in the future as well. Thank you.
Thank you very much, everyone. Have a good night.
Thank you. Good night, everybody. Thank you very much.
Thank you, sir. Thank you so much, sir, for joining. Kisri, thank you.
Thank you.
Panduka, sir,
Thank
thank you.
you.
Ashwini.
Good night.
Good night. Lakmal, thank you. Media